All right, 5:30. So really quick, I'm going to keep this as brief as possible so we can get started right on time. Just for everyone who's here, we now have 32 people, which is very exciting. This is the first time we've done anything quite like this. Thank you, Mike, so much for being here. Most of you probably know who Mike Suter is. If not, he's a physical therapist who owns a practice called Northwest Rehabilitation Associates up in Salem, Oregon, and he does amazing things for lots of different populations. And today we are going to be hearing from him about, as you'll see on the slide, the reality, importance, and applications of dual task training. This is going to be a 25-minute talk with 5 minutes for questions afterwards. So we are asking that you stay muted because sometimes if you're not muted, even background noise can kind of interrupt the presentation a little bit. So please stay muted. Hold questions till the end. You can type them in the group chat and we'll make sure that those get answered at the end of the talk. I'm just really excited. So let's go ahead and get started, Mike.
Great. Thanks so much, Claire, and everyone from the NeuroCollaborative. I'm very much looking forward to this, and we'll certainly interact at the end. If it looks like I'm bouncing back and forth a little bit during the presentation, most of you will know that that's just because I'm walking on a treadmill right now. And what better way to do that for a dual tasking webinar? So let's get started. So we're going to be practicing neuroplasticity. If you want to throw out a hashtag later on that, this would be what we might select. And very briefly, this is what we're going to cover: the why, how, who, where, and when of dual tasking. So let's get started on that. First and foremost, why? Why do we dual task? Why would we distract our patients? Doesn't it sound a little bit reprehensible or a little bit just absurd to be able to dual task our patients and distract them when sometimes learning is hard enough? Well, these are probably my 6 top reasons why we would dual task with a patient. And you can read all those for yourselves, and I'm going to highlight them for you. Please know you'll get the slides at the end of the presentation later on tonight. But a lot of people don't realize that dual tasking is not only functional, but also very engaging for a patient who recognizes the function they're in. But also exposing someone to dual tasking can improve their capacity to tolerate a distraction. So habituation is what we take a look at there. And then also our ability to be able to automatize and force a single task to become even more overtrained, overlearned, and again, more procedural is much more efficient when there's a dual task superimposed. We also have to understand something that's often overlooked is merely the importance of improving someone's awareness to the effects of distractions. And then finally, really the efficacious nature of dual tasking to be able to demonstrate truly that a person is independent only within a loaded environment rather than just an environment in solitude. And what most people totally ignore, especially if they are not well read in the literature yet, is that dual tasking is not something you're just born with. It's trainable, and that's why. So let's take a look at a video here. We're going to take a look at Hunter here, who was not injured in this video, and he's prioritizing the leash versus the treats versus the treadmill. And there he goes. So prioritization is very important when we look at dual tasking. People, even animals, yes, learn how to prioritize the most important aspects of their environment when they're introduced to dual tasking. Imagine if you were never introduced to dual tasking, you might be overwhelmed and overloaded when first exposed. So now let's look at how. Dual tasking is improved through neuroplasticity. We absolutely have trainable capacities in dual tasking, and let's take a look at what happens there. The primary attention center, the dorsolateral prefrontal cortex, which you'll see here, the DLPFC, is our main attention center that selects and allocates attention according to your own perception of what is priority in your world at this time. Do I need to pay attention to the shirt that I'm putting on or to my sitting balance? And obviously, the examples could go on. But no matter the combination of tasks that you're working on, dual or multitasks, if you have the capacity to be able to proceduralize a task before you have a stroke, before Parkinson's disease or multiple sclerosis has its effects on you. Your ability to be able to go back and utilize and benefit from the representation of that very proceduralized task is really part and parcel with how you can improve your tolerance of a distraction. So the more we ask a patient to think about a task and to really cognate left foot, right foot, heel strike, don't snap your knee back, etc., the more we ask them to be cognitively engaged in a task, the more we're commanding and demanding that the dorsolateral prefrontal cortex engage in that task. When we ask them to dual task, we're asking to absorb part of the resources of the DLPFC, the attention center, so that the individual is essentially constrained. And yes, you can think about this as constraint-induced learning. The individual is constrained or forced to use the procedural memory centers, which you'll see down here: basal ganglia, supplementary motor cortex, cerebellum, premotor cortex. They're forced to be able to use those centers that are the natural centers performing the task of walking, dressing, brushing your teeth, etc., so that they are using the more natural centers to process the task. Now, let's take a look additionally at how. The trainable dual task resources that I've listed for you here, that I'm not going to read you all the way through, include those very same things that I've talked about you so far. You'll improve your capacity globally for attention, your tolerance for distraction, your awareness to be able to make a more appropriate decision, prioritize, and then also the rest that you see down here, not the least of which include your reaction speed and also your accuracy of decision making once you've become more exposed and experienced in dual task environments. So you think to yourself, we'll go back up one slide here, keeping in mind the very bottom, a lot of us think that tasks are automatized through repetitions. Maybe even 5 to 8 years ago, we'd say, well, 10,000 repetitions of whatever task it may be, putting, shooting a free throw, etc., you'll be an expert in that task. But that is not what creates the automaticity or the procedural nature of a task by itself. It's not just repetitions, as we see here in this. When an infant or toddler, perhaps, is actually taking their very first steps, certainly they need more repetitions to become automatized. But once they're distracted by their parents' facial gestures, people clapping, etc., very often that toddler will, just quite by nature of the distraction, fall. So we have to gradually become automatized in our capacity to be able to walk so that we can participate in secondary tasks such as facial communication, talking, carrying toys, chasing after a puppy, etc. So tasks become automatized through repetitions, but they additionally become automatized because we force them to become automatized or proceduralized by the nature of other things that we couple with them. So this slide, which again you'll receive later, this slide shows 7 different reasons. These are not the only reasons, but I would suggest the top reasons why tasks would become automatized. Interest is probably really the leading aspect to consider. So when you are dual tasking with your patients, I really want to make certain that you're following these bullet points as a model for what you're going to select to dual task with them. So are dual tasks efficient in terms of pushing an individual's capacity and procedural memory? Do we get better at the tasks that we have combined in a dual task nature? And I would suggest to you that Steph Curry, the second highest paid basketball player in the NBA, who routinely dribbles 2 basketballs in warm-ups before nearly every game, if not every game, is much better at basketball in terms of his capacity to hold and handle 1 ball at a time, primarily because of his regular exposure to dual tasking and dribbling 2 basketballs. Now let's move on to who? People that demonstrate the inabilities, as you read the following here, those 6 different inabilities those are individuals that primarily should be targeted for dual tasking. Now, this is pretty straightforward. I'll let you read this for yourself. I just want to highlight that individuals that are tested to be more intolerant of adding a secondary task will naturally show a measurable change, a dual task cost or loss in their ability to perform the single task. So we essentially could include everyone in terms of a category and diagnosis for this, but we don't want to go overboard and suggest dual task is the only thing that should be done with every person. So we pare it down a little bit more and we attempt to be very scientific about it. And this slide reflects some of the diagnoses and then also some of those more accurate descriptors. Now, again, primarily you would want to be able to test someone to demonstrate that their performance in a single task experience is actually measurably reduced when combining a secondary task. And we'll get into that. So some very straightforward examples here. People that need to be able to dual task include this slide that you see here, carrying packages or negotiating traffic. People that need to hurry to the restroom or combine a secondary task in. People that need to combine in an ADL or instrumental ADL while doing or participating in another task. Now, it may surprise you a little bit that I'm going to also suggest that includes swallowing. And I do that primarily because swallowing truly is a procedural memory, a task that by itself in solitude is procedural and automatized. And many individuals aspirate when they are not concentrating purely on the swallow and when they're distracted at the Thanksgiving table. How about these two ladies? Avocation. Do you think that they're really participating cognitively in what they're doing manually, knitting? Or do you think that that's very secondary, very proceduralized, and now very automatized for them because of the numbers of repetitions, but also because of the sheer nature of what they do while they're knitting? How about this? This is a pretty straightforward example and something that can truly give a lot of individuals that bring it home experience that dual tasking is very necessary to be successful in a primary focused task. Here's Rajon Rondo of the Boston Celtics, probably just 5-6 years ago, attempting to shoot a free throw. Obviously, he's on the road, meaning he's at a visiting arena, and he's got plenty of distractions. Believe me, not just visual in nature, but also auditory. And we'll get back to that point as well. So the commonality here that we see is procedural memories are those tasks that can be not only automatized, but also can be trained to become more proficient with the combination of a secondary task. I already showed you the free throw about brushing your teeth when you're learning and then making that task automatized. How about driving a 5-speed car? And certainly dressing a button-down or button-up shirt. So now let's move on to what? Well, what we're actually doing when we're helping someone improve in a dual task capacity is we're improving the attentional resources at the DLPFC, the speed of decision making, the skill really of that primary procedural memory, and I do mean the insulation. So the ability to be able to insulate and protect a procedural memory under the force or duress of dual tasking. As I mentioned earlier, the awareness, the capacity to inhibit, select, filter, or shut out distractions so that you can prioritize and improve your capacity to hold on to the solitude primary task. Tolerance, and yes, I'm going to put that into the category of habituation, a term that you might use primarily for vestibular rehabilitation. Think about exposure type therapy. And now let's move on to finish up the consideration of what? So as I suggested earlier, dual task training is in fact categorized as constraint-induced procedural processing. Now, constraint-induced meaning that through the introduction of a secondary task, you are arresting or utilizing some of the resources of the primary attention center, forcing that in combination, the secondary task be processed down into the procedural memory centers, basal ganglia, cerebellum, supplementary motor center, as well as the premotor cortex. So truly constraining or forcing the reintegration and automaticity therein. Now, constraining the attention center is exactly what happens. So I want you to hold on to that concept for just a moment of constraint-induced learning. So this is a very simplified pictorial representation of the dynamics of dual task. What happens? Number one, we attend when we can and when we need to using the primary attention center. Right up here, the DLPFC. Number two, when the DLPFC is overloaded, we may literally push a task to the procedural memory centers, abbreviated here by PMCs. We rely on the premotor of the procedural memory centers when skill or attention demands indicate. Now, I've just represented here the basal ganglia, but please note, and I've just done that for the simplicity of this slide, it also does include all four of those centers, not the least of which would be the cerebellum. So when we're cued to or encouraged to attend to the primary body parts, we pull that capacity of the procedural memory center taking over the natural process, and we pull it right out and throw it up into the motor strip identified here as M1. So if we take our patient's attention and draw it too much into the internal aspects of their movement, we may be interfering with their capacity to learn and their capacity to hold on to some of the learning that we're trying to impart on them. Now, you may see that this relates quite nicely to the optimal motor learning theory when we talk about an external focus rather than or instead of an internal focus. And this is why. Now let's move on to when. When do you effectively introduce dual tasking? Certainly it wouldn't be appropriate to do this at all of the time when an individual is just starting to learn. So some of the first four theorems that I would suggest to you, if you're looking to answer the when, is we want to make certain the summary being that a patient has learned well enough that they're starting to be able to demonstrate some self-monitoring capacity. So we want the patient to be able to recognize some of what is happening from a sequencing standpoint in gait or even in ADLs. Some of the self-awareness capacities that comes into recognizing a loss of balance. And so we're looking at emergent awareness. When a patient is demonstrating capacity to recognizing a problem as it is occurring, doesn't mean they're perfect, doesn't mean they're correct in their solution of the problem, but they're just starting to demonstrate some level of awareness. Okay, so as summarized down there, you can look at all of these points, but really the overview is emergent awareness. Now, on intervention. In intervention of dual tasking, we need to consider all four modalities. We'll get to exactly what those are in a moment, but I want you to understand that just as I suggested with the free throw shot in basketball, we saw that the player was certainly dealing with visual distractions, but I hinted to the fact that there was going to be more than just that, probably at least auditory distractions. Now, if you additionally consider the concept of pressure, the context of the game, how important that free throw is, we would certainly have a third level. So we've got the visual of the fans, the auditory of the fans, the cognitive nature of the circumstance and context itself, at least those three. And I'm certain you can probably guess what the fourth modality distraction would be. But moving on, you understand that the most important concepts to be able to intervene appropriately are to consider what is necessary for this person that I'm working with to be able to do a task. Do they live on a farm? Do they need to be able to combine dual tasking that is giving respect to where the other animals are as they're going out to feed them, carrying 2 5-gallon buckets of feed? Do they actually live in the city and they need to be able to interact with pedestrian traffic? We want to consider salience, importance, and motivation first and foremost. So functional reality, Then we move into strained tolerances, and we take a look at the true dual task cost that this individual is experiencing. So finally, those 4 modes of dual tasking, as I've suggested, and briefly summarized here, include the cognitive, auditory, visual, and manual. So when we test or we intervene, we need to understand that the capacity to perform in one does not actually portend or predict the tolerance of another. Similarly, the training of one does not increase carryover toward another. So the next 4 slides that I've given to you here are really just, for me, some very basic applications that I would suggest that you could potentially incorporate in gait training. Now that could include in a body weight supported treadmill situation environment or on level surface walking. These would be manual, and I would ask you to read those for yourselves, but just to read the top one off: zipping, buttoning, and unbuttoning a shirt. So you can't see on your screen, but that's what I'm doing right now is unbuttoning a shirt. And you can imagine how that would be a manual distraction. Cognitive. One of my favorites to do is to actually have a patient while they're walking with you to relay the street by street, turn by turn directions that it would take for them to get from the rehabilitation center that you're working at them with all the way to their home. And that might be something that's appropriate, salient, and also common knowledge for them. Now, just one example for visual distractions. You could certainly do flashcard based. I try to keep it as practical as I possibly can. And you might actually have a patient loaded with 72 cents of change that you've placed in their hand and they've put into their left pocket. And they need to be able to pull out 50 cents to and do that while they're walking, certainly manual and visual. If you present the coins to them in your hand while you're walking alongside of them, that would be purely visual then as well. When I say purely visual, let's keep in mind that almost no distraction that's provided does not include some capacity cognitively. And then finally, we take a look at auditory. Auditory distractions could include music, podcasts, conversations, television, and then they could include things that you are asking them to be able to recall for later purpose. Now, we're going to look at a quick test right here. Okay, many of you would be familiar with the trail making bee, and that's what we've done there, just done it with an agility task on top of it. Another brief possible example of some dual task testing could include the cognitive 4-square step test. If this doesn't sound familiar to you, please don't worry. It's because we're certainly working on designing this right now. It's not out in validated research. So I'm suggesting to you here, take a look at this slide, perform the 4-square step test as a single task, record the score, and have patients then perform the 4-square step test again in one of these 5 different combinations. A lot of times I try to give patients autonomy so that they can choose one of the 5 different types of distractions to fold in. So those could be serial 3s, like you do with the cognitive timed up and go, or you can read any of the rest of those for yourself as well. So dual task motor learning is complementary toward the optimal. We engage patients. We use the challenge point framework, obviously, to be able to push patients at their capacity that's functional and engaging. And it's true, certainly, a complement to procedural memory training. Slides here, pretty familiar with the optimal motor learning of theory. The optimal theory of motor learning. And that's depicted here. You see the 3 primary tracks of which would include autonomy, enhanced expectancies, and external focus. And dual task training complements with all three of those. And this slide shows you exactly how that happens with the autonomy, the external focus, and expectancies all folded in for a person that gets the opportunity to select the distraction, focus on a goal, and expect the next repetition to be even more successful. Finally, the challenge point framework, where we try to increase the level of difficulty of a single task by combining in a secondary task and cause the improving learner to be more capable in a single task by challenging them at a higher level. The remainder of your handout here today that you'll see is just the bonus slides on the speed round. And so we don't need to go into those right now. We are ready for questions at this point, and I'll turn it back over to Claire.
Ooh, awesome. Oh my gosh. Thank you so much, Mike. That was amazing. So what we will do now is, if you have a question, I'm going to try to get it so that I can see more people. But if you have a question, you can either type it in the group chat, which you'll see if you're on your phone, there's a place where you can do the group chat, or on the screen if you're on a computer, you can click on chat and type something in. If you want to write it, I can ask that question. If anybody wants to just verbally ask a question, go ahead and unmute yourself and ask that question, and we'll try to just have it not be too loud. With multiple people going on at once, I'm still trying to get to a version where I can see more people. But feel free, if anybody has a question you'd like to unmute yourself and ask, go right ahead. One question I have, Mike, and I'll let other people unmute and get ready to ask a question. Have you ever had someone that you did not think that dual task was appropriate with?
Yeah, that's a great question. I've worked with several people with more advanced Parkinson's disease, as well as some individuals with Alzheimer's disease, that I felt that I would be overloading them, confusing and potentially agitating them. And that would be a time that I would choose not to dual task load.
Okay, very good. Yeah, and I thought there's some people where I would just make the dual tasking so simple. If there was something like even that they could be riding a bike, but start to incorporate like really simple dual tasking and try to just get them to keep pedaling. You know, that's very different than some agility with math and, you know, really high level dual tasking. But I've been trying to really incorporate something with everyone, and just at least at a minimum seeing what happens.
Yeah, that's great. And just the capacity, you would, many of us would be dramatically, I guess I'll just say shocked to see, even in ourselves, if you try to pedal a stationary bicycle nearly as rapidly as you can, or even at 70% of your capacity, how much you downshift that unintentionally just as soon as someone asks you a question. And it doesn't mean that you're dual task intolerant or deficient. There's a natural loss to that primary task, but it's always beneficial to be able to load someone so that they have that capacity when they're in the single task mode.
Mm-hmm. All right. And then anybody else? So I saw Pamela had raised her hand earlier. Pamela, if you would like to unmute yourself and ask a question, please feel free to do so. Then I have a raised hand from iPhone, but I don't actually have a name on that iPhone. Do we have any other questions, or do people need a little bit of time to absorb? And maybe we'll.
And certainly you can use my email address for later if you feel a little bit inhibited and asking questions in the group. Please do feel free to utilize that. I'm happy to address questions offline. And I believe we're going to have this will be recorded and shared. And if we have other questions that come up later that we can share back into the forum, we'll find a mechanism for that as well.
Yeah, definitely. I think a good place to ask questions is in our Facebook group, NeuroCollaborative Professionals. Any questions or thoughts afterwards, feel free to ask those, and we can all kind of jump in to share our answers. Desiree, I see, does have a question. Are you able to unmute yourself, Desiree, and ask that question?
Hello?
Yes.
Can you hear me?
Mm-hmm.
Okay. I was just curious. Hopefully this makes sense. So when you were talking about dual tasking, is it more important, like when someone's relearning a simple like functional task, is it more important that the dual task is relevant to the primary task itself, or is it more impactful if they're doing a primary task but a dual task that is of interest to them? Does that make sense, or am I?
Yeah,
Did you already
that
ask?
makes a great deal of sense. That's an excellent question, as a matter of fact, and that is going to come down to a person-by-person basis. I would hesitate to say that there is a definitive answer on that, and I would tell you that most likely what would be most engaging to the patient should be the most important to be able to layer on. So when you ask the question, just to reset it for the audience, should we combine a secondary task that normally goes with this primary task? Who are we to say what normally goes with it? Do I normally, listen to NPR, have a conversation with my spouse while I'm brushing my teeth, getting dressed, etc.? Or is it, common for someone to play video games while they're doing some of their primary task and getting dressed in the morning? So I would hesitate to say that there's a definitive answer, but I would lean toward engaging the patient.
Okay, thank you.
All right, and then a question that we had from Michelle was, how do we know which task the patient will get better at, or is it assumed that they'll get better at both tasks?
Yeah, that's another great question. So research tells us very clearly that when we're going to engage a patient in dual tasking, that 3 different approaches should be taken. Number 1, you should occasionally cue the patient to prioritize the primary task that you are directed to, or challenged or charged to improve, be that walking or bed mobility, dressing, whatever. Additionally, a second track that's important to do is to cue the patient to try to pay some attention to the secondary task. And then track number 3 that's important to do all 3 of these is to actually provide no cue whatsoever for prioritization. We would expect the patients, by nature of when we introduce secondary tasks, remembering that we're not doing it when they're novice learners for any given task, we would expect to answer the question by saying they should improve in their tolerance of the distraction and their performance of the primary task. But in so doing, we would want to make certain that we're cueing in all 3, either no cue, pay attention to the cognitive, or pay attention to the primary. Great question, though.
I have a question. Hello?
Yeah, we can hear you. Go ahead.
Oh, sorry. I was just wondering if any of you have some words of wisdom or clinical pros for a patient that's struggling with gait stability because of Parkinson's, but their number 1 goal is they want to be able to be safe while walking their dog. How would you guys approach that? Or what might be some tips?
Right, so that's a great question. So I would always approach that with a single task first. Let's get some measure of how capable this individual is in walking their dog without a distraction. So you could do some sort of time measure across the room or down to a mailbox, the number of loss of balance, the cues necessary to keep their posture upright, the number of times they have an incomplete stride, strike their foot, or even the number of steps that they take to carry a certain distance from the home to the mailbox while they're walking their dog. So measure that capacity in a single task. Now what we'd want to do is inform the individual, I'm going to try to load you up. I'm going to try to see if I can distract you from thinking about the primary task of walking. Now, we might use the optimal modal learning theory and say, I'm going to count the number of steps that it takes for you now to get to the mailbox. Let's see if you can keep it at a low number of steps, meaning you're taking large strides to get there, if that's chosen to be the most appropriate and safe for this individual. So you're telling them that you're going to load them and distract them. They're trying to prioritize the primary task and to be able to demonstrate that even while walking the dog, they have the capability of being able to maintain that safe primary task. So I'll restate one thing. I would do it in single task without the dog, measure it, then dual task it with the dog, and see what the dual task cost is. Takes you 115 steps to get there in single task but it takes you 181 steps to get there in dual task. Taking a look at the differential, you've got a way to be able to chart the difference, and more importantly, a way to be able to engage the patient so that they're trying to shrink the measurable difference between the two. Hopefully that helps you some.
Thank you so much. That's great.
Yeah,
All right.
thank you.
There are definitely more questions coming in, and I bet we could probably talk about this for another hour, but I want to be really respectful of Mike's time because he did agree to come on, but he's got a busy schedule. So what I would like to do is I'll collect the questions that have come up on the chat, and I'll post them in Facebook, and I'll connect with you, Mike, and we'll make sure to just kind of continue the discussion. So anything else that comes up that you guys think of, you can post in the Facebook group, and we'll send out a follow-up email with the slides and the video. We'll make sure to have contact information for Mike so that you can contact him directly. And of course, you can respond to any of the emails that we send out. If you have any questions for Aaron or I, feel free to just respond to those emails. But I think this has sparked a lot of interest. That was an awesome presentation, Mike. And I think will be a lot of follow-up discussion and a lot of people adding more dual tasking to their therapy sessions tomorrow.
Excellent. Thanks so much for the opportunity. If you're not already a member of the NeuroCollaborative group, they didn't ask me to actually give this shout out, but please, I'm a very big supporter and I love what they do for our profession. So please do consider that. Thank you again for moderating, Claire. And you all have a good night. I'll look forward to your questions.
Thank you. Have a good night.